All right, it is 10 a.m., so we will go ahead and get started. Once again, thank you all for being here. I know this is a super busy time of year, so we really appreciate the fact that you've all made the time for this presentation. And Dr. Marshall, thank you for making time to bring it to us. We all know this is a super important topic this time of year. First, I'm going to tell you just a little bit about the WellCats program. And how you got here. So, WellCats, let me make sure I have my slides up for you. WellCats is your Texas State Employee Wellness Program. So we offer you group exercise classes, cooking classes, nutrition consultations, stretch breaks, which stream on our Microsoft Teams channel. And then, of course, these wellness education series that you are here for right now. We provide these on a monthly basis on all sorts of wellness related topics, and we try to bring you fantastic presenters like Dr. Marshall to talk to you about important topics related to your overall health and well being. So, this month, we are bringing you Sleep Hygiene 101, building a nighttime routine. Um, we know that this time of year is especially busy. We tend to have very long to-do lists, and we tend to let our self-care and well-being kind of slip onto the back burner. So Dr. Greg Marshall, who is a professor and chair of the Department of Respiratory Care and the Sleep Center Director for the Ascension Seton Williamson Sleep Center, is here to help share with us some effective strategies for improving our sleep quality, boosting our energy, and managing all of this holiday stress. So thank you again, Dr. Marshall, for being here. We appreciate you so much. And I'm going to go ahead and pass it over to you.
Great. Thank you so much, Jess. I appreciate it. And welcome, everyone. I hope the sound of my voice and the slides don't put you to sleep. But if it does, that's a good thing, right? And we'll study you. All right. So hopefully you'll stay awake for the next few minutes here to go over Sleep Hygiene 101, building a night routine. Um, and a little quote from Shakespeare, to sleep, perchance to dream. Ah, that's the rub. And that'll make a little bit more sense as we go. So thank you. Let me get us going here. Uh, I really toned down my 12 objectives to 4 so we could get through this in time and tried to really think what would be most relevant to you to hear. Some of you maybe have not studied sleep very much and know much about it, and others may, but we'll get on the same page here. So here's what we're going to do. We're going to be looking at the national sleep statistics just so you kind of know what's going on in the US. We're going to identify the normal stages of sleep. We're going to describe the 3 major types of obstructive sleep apnea, and we're going to discuss lifestyle interventions for sleep difficulties. So you may not have ever heard of the ICD system, but the World Health Organization put this together. It's followed by the whole world, so that literally the methodology of arriving at a diagnosis is the same in Paris, France, and in Scotland, and in Africa as it is in the United States. And we do this so there's continuity and agreement, and so that professionals can talk to other professionals and be on the same page. Sleep, interestingly, is part of Chapter 7 under sleep-wake disorders, and I just wanted to bring those to your attention. The first type of sleep disorder is called a dysomnia, and a dysomnia is excessive sleepiness. People who fall asleep at a stoplight, in a movie theater, trying to watch a movie at home in the recliner, or also including insomnia. So it has, as part of its group that's under the dysomnia, is insomnia, narcolepsy, obstructive sleep apnea, essential sleep apnea, periodic limb movement disorders, hypersomnia, and circadian rhythm sleep disorders. Now, that's just the tip of the iceberg. There are over 140 different sleep disorders, and a lot of people don't realize that is a big pot of problems. The second type is parasomnia. and it's the behavioral sleep disorders. And if you've ever watched any of the YouTube things about the little fainting goats and all that, that's this group. Uh, they are REM sleep disorders, and it includes sleep terrors, sleep walking, tooth grinding, bed wetting, sleep talking, exploding head syndrome. It's a real interesting, but fortunately, not nearly as many people have parasomnia as most of them are the dysomnia group. There's also a third classification of sleep, which is medical and psychiatric conditions. And what we have found is that if we can solve first the sleep problem, many of these psychiatric issues can diminish or even disappear. It used to be flipped. They used to say, well, we're going to work on the psychiatric side of things, and when we get you fixed there, then we'll work on sleep. But we've come to realize that sleep is such an essential part that there's healing that can come if people are getting enough sleep. Sleeping sickness, we don't have too many tsetse flies in Texas, so we don't worry about that here. Snoring is a classification all its own. It's never correct to snore. Even a tiny snore is going to indicate that there's an obstruction to taking a breath. And then lastly, the sad group of little sudden infant death syndrome situations, and that is the sixth classification of sleep. Looking at the sleep stats, just this is a busy slide. Very briefly, sleep stats, 1 out of 9 folks in the US have a sleep disorder problem, and that's approaching 45 million Americans. And so we do have a real problem with it. And I know that you and I think about this when we get on wonderful I-35 and we have all these 18-wheelers that are whizzing past us and we're trying to get around, and they have a real problem with sleep. But thankfully, the government has really clamped down on that, and they require them to only be able to drive so many hours, and then they have to stop and sleep. So it's a real problem for sure. So the big missing question is, how are you sleeping? One of the most neglected assessment questions is this very thing. How are you sleeping? And if you think about it, when was the last time that your personal physician asked you, how are you sleeping, if you went to see him or her for reasons other than sleep? And we probably say very few of us. Typically, in a group, there's only about 20 to 30% that their physician has ever brought it up. And we know in academia, if we're scoring 20 to 30%, you get a big F. And so they do. But it's becoming more and more important to physicians to ask. And so that's a good thing. And of course, college students are the worst. Uh, Normal sleep efficiency, which is one of the calculations that we look at, is about 85%, which means 85% of the time that you're in the bed, you're actually sleeping. But college kids are 55 to 72. So it's a huge issue for them, and we see that in the classroom many times. Two terms to get under our belt here before we can take off here: apnea and hypopnea. And I think almost everyone probably has heard of apnea, but we have a very measurable definition of it. It's cessation of breathing for 10 seconds or longer than, are longer, 10 seconds or longer, with greater than or equal to 30 apneic episodes in both non-REM and REM over a 6-hour period. And we'll talk about non-REM and REM in just a second. But so it's a measure, we can actually measure the timing of the cessation of breathing. And if it meets that criteria, it's labeled as an apnea. The second term is hypopnea, and medical terminology is really lots of fun in medicine because the prefixes and suffixes have a real meaning. So hypo means low, pnea means breathing. So guess what? Hypopnea is little breathing. It's a decrease of airflow greater than 50% of the wakeful airflow, and also a decrease of the oxygenation by 4%. So very technical classification and definition, but that's very important for both these terms because the apnea hypoxia index is what is used to award the diagnosis of sleep disorder and sleep apnea. So let's remind you of stages of sleep. And maybe you've had this years past. We all heard it in a psychology class or a health class. But let me just remind you that we have two primary stages of sleep: non-rapid eye movement and non-REM, and rapid eye movement, which we have heard a lot about REM sleep and dreams. Non-rapid eye movement is basically that first portion of sleep where the eyes are not moving. There's really a focus on this because it's one of our chief tells about what's happening with sleep. So with non-rapid eye movement, it's the first beginning stages of sleep that you and I have. And during that time, it's very interesting. The brain is resting, but the body is active. So the brain kind of gets its sleep during non-REM and the body is still active. And you probably have experienced this. You're falling asleep, you're very close to falling asleep, and all of a sudden you jerk and kick. All right, that's normal. That's a hypnagogic jerk, and it's allowed. And don't worry about that. But sometimes we'll experience that. That is proving that the body is active. And then with rapid eye movement, the eyes are not, or, I'm sorry, or the eyes are moving very, very quickly underneath our eyelids, are rolling around. And so in this is kind of flipped now, and the body is resting, but the brain is active. And we know that's because it's in dream state. So non-REM has two stages, stage one and two, and you can kind of think of it, levels of stages of sleep is getting deeper and deeper and deeper. When you and I went to bed last night and we closed our eyes and we finally began to sleep, we were starting at stage one. And then as we slept a little deeper, we were in stage two, and then finally in stage three of non-REM. And stage one, we're very light sleeping at that point. The dog barking or something buzzing in the house or even a doorknob turning will wake us up. Stage two is just a little bit deeper than that and a little bit more difficult to wake up. But during stages one and two, the respiratory rate and the depth of breathing is variable. We may have periods of apnea. We have alpha waves are kind of what is happening to you and I right now. If we put an EEG sensor grouping on our heads, what we find is that as awake individuals, we all would have alpha waves. Um, and that's what's going on there. We're losing the alpha. And then stage three is a real important stage. It's also known as slow wave sleep or delta waves. And this is the restorative sleep. When we get enough stage three, we wake up in the morning and wow, we feel great. We slept really, really well. So restorative sleep in stage three, hugely important. We want to do everything we can to encourage that. Ventilation changes, the amount of CO2 and pH and oxygenation changes because what's happening is the ventilation is slowing down. And it lasts about 60 to 90 minutes, floating between stage one, stage two, stage three. Oop, now back up to stage two, stage one. The dog barks, maybe stage one. And so we kind of float in this stage one and two non-REM in all those phases. But we spend most of our time in phase two. Like I said, with non-REM, there's muscle tone and muscle movement. And so you can even pull up your blanket and not wake up and maybe flip your pillow to the cool side and not wake up. Non-REM represents about 75% of the sleep period with those wonderful restorative slow wave sleep or delta sleep in stage three non-REM. This is very disturbing research I thought I would share with you. The long-term effects of reduced slow wave sleep. So slow wave sleep is hugely important for a lot of reasons that we'll visit in just a minute. But especially in slow wave sleep, there's an insulin issue that's going on. So what they did was they found some college students who were willing to sleep for 3 nights for $100 a night, and of course, about every student would be happy to sleep for $100 a night. And so they of course, the student didn't understand what was going to be happening. They just knew they were going to get the sensors on their head and on their body that we use in a sleep study. And what happened was, as the patients, or I'm sorry, as the subjects were falling asleep and they were in non-REM one, and then a little bit deeper to non-REM two, and then a little bit deeper to non-REM three, when they got to non-REM three, they sounded a buzzer and woke them up just a little bit so that they pulled back out of non-REM three into two or into one. And they did that all night long. So they never got to get to stage three and get restored to sleep. They did this for 3 nights in a row. And look what's happened here. Uh, they became less sensitive to insulin. And because they needed more insulin to dispose of the same amount of glucose or blood sugar, their insulin secretion didn't increase to compensate, resulting in a reduced tolerance to glucose and an increased risk of type 2 diabetes. In 3 nights, healthy adults became less sensitive to insulin and were at higher risk for type 2 diabetes. And that's equivalent to comparatively gain 20 to 30 pounds, because we do great with insulin and glucose management with muscles, but not very well at all with adipose or fat tissue. So in 3 nights, these individuals really got taken to a type 2 diabetes predecessor place. And we need slow wave sleep, don't we? Absolutely. The other stage is REM, rapid eye movement. And of course, this is named very interestingly because when sleep was first being studied, they were just watching. And what they noticed is that as they went deeper and deeper into sleep and went through the non-REM one, two, and three we've talked about, they finally landed in REM and their eye movement took off. Not necessarily opening, but eye rolling all around in a circle to the right, to the left, and then rapid movement of the eyelids. And that's why they named it rapid eye movement, REM. Um, It's our dream state. We know that. And so important to also get into REM. But here we have, remember, the brain is active, but the body is not. And so there's a profound sense of paralysis of all skeletal muscles. You lose tone. You have loss of respiratory muscle tone. It will decrease your respiratory rate, and you'll have some abnormal chest wall movement because of it. It really does take us to a different place. And you probably have experienced this sometime in your life when you woke up in the night and you couldn't move, and you wanted to scream, you wanted to do something, and you couldn't move at all. What happened in that situation is that you surfaced very quickly to the wake stage out of REM without spending time in non-REM, and it happens sometimes when we're abruptly awakened. The waveforms look very similar to wake. And so that makes sense because there's things, activity in the brain is very, very active at that point. Ventilation changes. And this is a little interesting to learn that for normal adults that do not have the sleep apnea uh, diagnosis, we are allowed to have 15 to 20 seconds of apnea, um, 5 events per hour, and that's considered normal. So it's part of our sleep architecture that we have this movement back and forth between REM and non-REM. With infants, it's a little bit shorter, 10 seconds of apnea and 3 events per hour. Heart rate is irregular and eye movement is irregular as well. So we've just mentioned this. There's loss of tone, but most importantly, there's loss of tone of the muscles in our throat, in the oral pharynx, just on the other side of our tongue, in the back of our throat. So the loss of tone causes those muscles to relax and to narrow the opening with which we're using to breathe. And so it results in snoring and apnea and gasping and disrupted sleep. So someone who is suffering from obstructive sleep apnea, when they get to REM sleep, because there's muscle paralysis, They get pulled out of REM uh, because the narrowing causes snoring, and they may be so obstructed that they're completely obstructed and will sit up in the bed, gasp and take a breath, and then lay back down and go to sleep. Even though their eyes were open, they never woke up. They were in non-REM 3 or 2. So it's a real interesting time for the body. And if we have any kind of obstruction, it is a problem. And here's what I tell students that, don't worry about sleep. REM enhances learning and memory and contributes to emotional health. So we really need the REM to take place. Uh, we were doing a sleep study on a football player, not a current one, but years past, and some research we were doing, and he was really struggling, and we were trying to help him get things taken care of. And I asked him the question. He was a big, huge lineman. I said, when was the last time you had a dream? So you know what I'm really asking is, does he ever spend any time in REM? But I didn't explain that to him. I just said, when's the last time you had a dream? He says, oh, wow. He was 19. He said, maybe when I was 12 or 13. So not a good thing, means that REM was being missed for many, many years there. And we did help him. So like I said, beginning with non-REM, stage one, we kind of float between 1, 2, and 3. It takes about 30 to 60 minutes for that to happen. And then we finally transition into REM. REM will last anywhere from 5 to 40 minutes. And then we'll cycle back to non-REM. So we do this cycling thing between non-REM and REM because different parts of our body are getting rested and restored every 60 to 90 minutes. So we normally have anywhere from 3 to 5 REM episodes every night. So you and I have 3 to 5 dreams because when you're in REM, you are dreaming. May not remember that, but 3 to 5 dreams every night. All of this is crazy looking lines, I know, for you to see, but a couple things to point out. Starting at the very top, that's the way you and I look right now as awake, and those are called alpha waves. And so they have a very distinctive pattern. And then as the patient gets drowsy, you can see it slipping down to the next one. It changes. You can see a difference. And so you actually know that they're entering into stage one non-REM. And then once they get into stage 1, 2, and 3, you can see again the waveforms are changing. Stage two, and look at the delta sleep down there, the big, huge, slow wave. And that's what that looks like, very, very exaggerated, enlarged waveforms. And then finally into REM, and look at REM and compare it to the top of the page to your awake alpha. It's very, very similar. So we know the brain is very active during that time. We also like to look at longitudinal sleep studies so that, coming into a sleep lab and having a sleep study done is great for a snapshot, right? It's a Kodak moment, and all it really does is tell us for that night, here's how the patient was breathing. What's maybe more important for us to look at is to think about, well, over 2 weeks or, 18 days, how is our pattern looking? So when we take a look at the weeks, days and weeks, we get a circadian pattern that we can recognize. And it's very helpful for us to begin to look at some other diagnoses if we're trying to help someone get to their best sleep. Uh, there you go. So this is a normal sleep cycle. And so I know this is maybe something you've never seen before, but this is tracking 13 days, 24 hours a day for 13 days, a little almost like a Fitbit or almost like your iPhone watch, except it's much more sophisticated and measures a few more things. Um, that's on the wrist, the non-dominant wrist of these subjects. And the blue represents, you can see there's not many black squiggles in the blue. The blue represents sleep. And so we already know that when we're sleeping, we're going to have less movement. And so that's what's happening. The black lines that are over the beige part represent activity. And so, some days we can see for this individual, like on 11/11, down there, they didn't have a lot of activity. And but you go up a couple to 11.8 and you see, wow, they had a lot of activity. They must be at the gym or something and really working out. So all of this gets recorded. The thing I want you to appreciate here is that it looks like that there's a pretty uh, regimented time to go to bed, sleep, and time to get up. So if we look in the left-hand column, it looks like maybe about 11 o'clock-ish, sometimes a little earlier, sometimes a little later. The In the evening, this individual is falling asleep and they're waking up. Looks like they have their alarm clock set for 7 a.m. because it's about what's happening with the wake up time. So having a regiment of starting and stopping sleep is really important. Trying to go to bed at the same time every night really makes a difference. This is insomnia. Isn't this a mess? There's no nice equivalency between days at all. It is scattered everywhere. It's all along that 24-hour period. And if you've ever known anyone with insomnia or ever struggle with it at all, you know what it's like. It absolutely is frustrating to them because they want to go to sleep, but they can't go to sleep. And they begin this kind of love-hate relationship with the bed. And we can do things to help them get on track. But the most important thing is they have to realize what's going on. Everyone that comes to our clinic that has insomnia and puts one of the little watches on, they say, I never sleep. I just don't ever sleep. And we say, well, we're going to find out when you're sleeping. And lo and behold, they're falling asleep at 6 and 7 in the morning after having a fitful night and sleeping through hours and maybe until afternoon. So we'll have students that are very upside down in their sleeping and have the insomnia problem. And there's things that we can do. We'll talk about that as well. Now, I always tell students this is your diagnosis. You can call mom and dad tonight and say, Mom, Dad, I've been diagnosed with delayed sleep phase syndrome. Oh, I'll need probably another $100 every month, right? So delayed sleep phase syndrome is very typical sleep disorder. It is an actual sleep disorder for college students because what they do is they're pushing their sleeping time down the line. Instead of going to bed at 11 at night, they're going to bed at 3 in the morning. Whether they're studying hard or whether they're in social fun with their friends, everything gets delayed. And then they go home for spring break, and guess what? Mom and dad turn out the lights at 10:30, and there's no way they can go to sleep. So it can eventually be reset to a normal schedule, but it can't happen quickly. So delayed sleep phase syndrome is what all of our college guys are living with. And then in my world of healthcare, in nursing, in hospital work, respiratory therapists, those of us that are up all night long taking care of patients, this is the shift worker syndrome. And this is a real problematic way of life. We have to have people in the hospital, especially at night, to make sure the patients are doing well. But it's really tough on the individual to be flipping back and forth between sleeping at night and working at night. And everyone works out something that works best for them if they're a shift worker person. But shift worker syndrome is actually a diagnosis. So let me tell you, if slow wave sleep is our restorative, wonderful sleep, let me give you some enemies of slow wave sleep. Any over-the-counter medication that is a sleep aid has a PM is bad news for stage 3 slow wave sleep. There are the chemicals that are in all of our PM things, Sominex, Benadryl, Tylenol PM, any of the PMs, Unisom, even cold and allergy medicines are going to not allow us to spend time in stage 3. So it robs us. And if you've ever tried taking any of the PMs at night, you know what it's like. You wake up the next morning, you know you slept all night long, but you feel so grogged and so tired and lethargic. It was just a miserable, miserable day following that. So anything with a PM, stay away from that guy. I'll give you some answers here in a minute for what you can use. Alcohol before bedtime. You're not going to like to hear this, but that's not good. The little nightcap thing is can really push us into obstructive apnea. And then, of course, smoking before going to bed, not a good idea because it's a stimulant and it will increase the sleep onset time. So it takes longer for these individuals to go to sleep. When we get the slow wave sleep disruptive, it really wreaks havoc on our neurotransmitters and stress hormones because they're being released big time in non-REM 3. It can cause impaired thinking. It can cause emotional issues. Uh, Insomnia will absolutely amplify any psychiatric disorder. And so that's why we go for let's do something about sleep because we can do that quickly. And more than 84 identified sleep disorders in this grouping itself, although just like I said, about 140 total last count. So here's the assessment. Am I having problems sleeping? Okay, so these are some questions that we ask patients to kind of add up a score, and it actually is a great predictor of needing to have a sleep study. Are you tired in the morning? Do you snore? Somebody will tell you. Do you fall asleep quickly? Are you sleepy during the day? Do you wake up at night? And then we might say to them, open your mouth and say, ah. And we're going to see what that's about in a second. But these are questions that we use that are found on a sleepiness scale that is a an inventory, a pencil and paper inventory that someone can take, answering the questions 0, never, 1, sometimes, 3, often. So 0 to 3 for each of these questions will add up to a number, and if it is greater than 9, it really means the person probably has a sleep disorder and needs to have a sleep study done. So what's the big deal about open your mouth and say ah? Well, here it is. This is called the Mallampati assessment. It's great because you don't need any equipment. All you have to ask them to do is to open their mouth and say ah and take a look. Class 1, that top left there, is totally normal. And so what we can see are anatomic structures there. We can see, of course, the tongue. We can see the uvula, the little hangy downy thing in the middle there. We can see the soft tonsil, or the tonsils, I'm sorry, and the soft palate and the hard palate. So we have those 5 structures that we can easily see. And if someone is class 1, it is very unlikely that they would have snoring problems. Class 2, you can see what's happening here. Things are beginning to be hidden. The uvula is a little bit hidden, tonsils a little bit more hidden. Class 3, even more so. And then class 4 is we really can only see the hard palate and the tongue. The reason this, very interestingly, is part of the whole assessment is because we're really looking at how much room does uh, your breath have to get around our normal anatomic structures. And it turns out that if you have class 1, we said that that's kind of normal. That's what we've just identified, the tonsils, the uvula, the hard and soft palate. Class 2 begins to be obliterated, 3 even more, 4 is only the hard palate. And the reason that's important is because we found by comparing them to sleep study subjects that if someone has a class 1, 2 Mallampati, that is normal to mild obstructive sleep apnea. If it's a class 3, moderate to severe obstructive sleep apnea, and if it's class 4, it's a severe. So the Mallampati index or score is very, very helpful to, again, we're trying to find what are the symptoms compared to diagnosis that's needed here. So what are the signs and symptoms of a sleep disorder? This is not a fun list. Morning tiredness, excessive daytime sleepiness is what EDS stands for. Morning headaches. It's not normal to wake up and have a headache every morning, but there's a real physiologic reason if someone has sleep apnea. Recent weight gain, impaired memory or attention, changes in mental status, lethargy or tiredness, weakness, hyperactive behaviors. Kids will, when they have a sleep disorder, it's kind of like what sugar does to us compared to them, right? Sugar to us kind of slows us down. We know that sugar to kids makes them just really be very active. And so, same thing happens with sleep. If a child is not getting enough sleep, they can develop very erratic, hyperactive behavior. Depression, pulmonary hypertension, I'm sorry, and systemic hypertension, blood pressure goes up. Pedal edema, that's swelling of the feet. And then very interestingly, and again, this is about anatomy and how crowded is the back of the throat. Neck size. Males that have greater than a 17-inch neck are higher risk for obstructive sleep apnea, and females with a 16-inch are greater circumference. So with obstructive sleep apnea or any kind of sleep disorder, let me kind of give you some insight what's going on. You see on the left normal breathing, and the blue represents the breath that's being taken in. When you and I go to sleep at night, and this happens to all mammals, uh, we become obligant nose breathers. We breathe only through our nose. That's why we get so miserable trying to sleep if we've got any kind of nasal discharge or any kind of upper respiratory infection or problem, stuffy nose. Um, Normally, what you and I do is we only breathe through our nose. And so the mouth, you can see there's the blue stops kind of there, and everything is coming through the nasal passages. And you compare that to what happens when someone has obstructive sleep apnea. They try to breathe in through their nose, but remember what's happening, either due to crowding of the anatomy that we just talked about, or other issues, the tongue relaxes and falls in the back of the throat and pinches it off so that they can't get any air through their nose or through their mouth. And so they end up gasping and waking up. So the clinical manifestations, we've kind of mentioned this: loud snoring, morning headaches, nausea, hypersomnolence, just as you're very sleepy all the time, personality and intellectual changes, depression, impotence, and nocturnal enuresis are clinical manifestations for sleep disorder breathing. Well, I'm not trying to scare you off if you ever have to have a sleep study, but here is what's going on. Uh, the the patient has about 24 to 28 little monitors or little electrodes on their skin, around their finger, around their arms and legs. And you might think, how in the world can anyone go to sleep? Remember, these people are very sleep deprived. They can fall asleep at a stop sign. So we get them all wired up and they get used to it and they're off. They sleep. There's not a problem with it. The tracings that we look at look something like this. So the top two are looking at left eye movement and then right eye movement, because we already know that if they're rolling their eyes and having rapid eye movement, that they're actually in REM state. And then the next four are looking at brain waves and helping us understand what stage of sleep they're in. We look at the heart, we look at snoring. If they're on any CPAP, we take a look at that. We'll talk about that in a minute. Movement of the chest and movement of the abdomen are recorded. The amount of oxygen in the patients. Uh, uh, the left leg movement and right leg movement are looked at. Even the body position, are they on their side, their back? Are they prone on their tummy? So this is one 30-second snippet from some patients' sleep study, and we look at every one of these 30-second snippets all through when it's read at the end and evaluated. Some of the kind of traditional move treatments for CPAP, I'm sorry, for sleep apnea is CPAP, which I'm sure you've heard the term before, but it stands for constant positive airway pressure. And what this does is basically this is a mask that can just fit over the nose. Doesn't have to be the nose and the mouth. And why is that? Because we're going to be obligate nose breathers when we fall asleep. A little bit of a leak is allowed, both from the mask and from out of the patient's mouth. But basically, what's happening is this positive pressure is pressurizing the nasal area and the back of the throat, which is called the oral pharynx, where the tongue is, and it physically pushes the tongue forward and out of the way so the patient can breathe. It's really amazing the difference that it can make. It does take getting used to. If you've known somebody that is using CPAP, they may have given up and said, forget it. But for people who persevere, it can really, really make a difference in how well they feel, and then the symptoms disappear. There is another new kid on the block here called a hypoglossal nerve stimulator. We're looking for sleep is interesting in that there's so much that we don't know about it that still is being studied. And you can have sleep specialists that are neurologists. You can have sleep specialists that are pulmonary or lung. You can have sleep certified docs that are ENT, ears, eyes, nose, and throat. And all of these guys have the same approach. They're looking for the solution. So here's one. Maybe you've seen this commercial on TV. It absolutely drives me nuts because it's a misrepresentation of what this whole thing is about. And it shows frustrated people with CPAP masks on. And then there's one guy says, he didn't have a mask on. He says, I just pressed the blue button. And I'll tell you, the blue button is a big deal. But for some people that cannot tolerate CPAP, this is a really good solution. Let me kind of explain it to you what happens. What happens is there's an implantable pulse generator, kind of like a pacemaker that's put under the skin that will detect the patient's breathing and will maintain an open airway by stimulating the hypoglossal nerve, which controls the tongue during inspiration. So if the tongue is the problem and falling in the back of the throat, what this research and development did was say, how can we move the tongue forward? Let's don't move it forward all the time, but let's move it forward when they are going to take a breath so that the airway can be open. Because exhaling is not a problem. It's inspiration. So the physician may adjust the stimulation setting using an external programmer, and then we take a look at the patient to see how they're sleeping. And so this blue button that they're talking about is remote control. And they click it, true, and they get about 30 minutes to fall asleep, and then the process begins. Now, this is a surgically implanted device. The surgery is about 4 hours long. It's pretty extensive. I've had a friend who has gone through this process and has benefited from it, but it was quite a recovery. Here's kind of what I've been talking about. You can look and see, first of all, there's a wire that's going up through the neck that attaches to the base of the tongue, and that's the hypoglossal nerve stimulator. Then in the inspired implantable pulse generator, kind of like a pacemaker, it's slid underneath the skin surgically, like a pacemaker would. And then there's a lead or a wire coming from the pulse generator to intercostal muscles or muscles between the ribs. So the thinking is this: when the patient takes a breath, the muscles in the between the ribs are going to expand. That is going to be recognized by this pulse generator, and it's going to shoot a pulse up to the stimulation lead, the hypoglossal, and cause the tongue to project forward. It projects so far forward that I mean, it looks like they're sticking their tongue out uh, in just a little way, but it's enough to get air around that. So this all night long, every breath they take, they're going to get stimulation to their tongue, and their tongue is going to stick out just for the inspiratory phase. And then during exhalation, the pulse turns off and the tongue goes back to its resting place and the patient exhales. Pretty interesting stuff. Um, some people really benefit by it, but it's a very invasive um, situation. Your dentist may have talked to you sometime along the line about an oral appliance if you have a sleep disorder. And we have a couple of different types of devices. They kind of look like torture, but they have a very wonderful purpose, and that is they move the mandible or the lower jaw forward because the tongue is connected to the mandible. So if they can displace the mandible and move it forward, they can absolutely pull the tongue out of the way. And some people really benefit from this as well if they couldn't tolerate CPAP. The tongue retaining device really does seem like a little bit of a torture device because it is a little mouthpiece that basically the tongue fits into. You squeeze that, and the suction causes the tongue to sit in that little open area in the center, and permanently during inspiration and expiration, pulling the tongue forward out of the back of the throat so the patient can take a breath. Another dental appliance, again, showing that the mandible is moved forward and adjustments can be made. There are little screws on the side that the individual can activate once they learn how this works. So what happens if you say, I'm not going to treat it. Forget it. Too much trouble. Well, here's what happens. These individuals come to us and they're very sleepy, hypersomnolence. It means they fall asleep anywhere and most everywhere. They have decreased physical performance, decreased concentration memory. Uh, they have psychosocial issues, impotence and decreased libido, reduction in the quality of life, high blood pressure, coronary artery disease, myocardial infarction or heart attack, congestive heart failure, and stroke. So, not treating it is moving someone towards these issues. And so, we really want to grab those 1 out of 9, 45 million people and make sure that they're getting some form of treatment, whatever works for them. So let me tell you real quick about the best and the worst foods for sleep. I thought that you would enjoy this. So we'll recognize some of those. Tryptophan is the first one, and we just had Thanksgiving and had turkey, and you've all heard that turkey has a high concentration of tryptophan, and there we all are afterwards, passed out on the floor in our stretch pants, right? So it's an amino acid that transforms serotonin to melatonin. And you probably have heard of melatonin as a sleep aid. We'll mention that in a sec. It also is found, tryptophan is found in dairy products, seafood, nuts and seeds, legumes, fruits, vegetables, and grains. Magnesium has been called the sleep mineral. It's a natural relaxant and deactivates adrenaline, which we all need. uh, Dark leafy greens, seeds and nuts, wheat germ, fish, soybeans, bananas, avocados, and low-fat yogurt. Calcium helps the brain to make the melatonin. And again, you can see a trend with these healthy items to eat, can't you? They're recurring. And so it tells us it's a good diet choice. Vitamin B6 converts tryptophan to the melatonin, which makes us sleepy. And sunflower seeds, pistachio nuts, flaxseed, fish, meat, dried prunes, bananas, avocados, and spinach. I'm getting hungry. And melatonin, our sleep inducing hormone that is made in the hypothalamus of our brain. Uh, we normally make this melatonin. We all have a melatonin level that we maintain. Oops, sorry about that. Fruits and vegetables, asparagus, tomatoes, pomegranates, olives, grapes, broccoli, cucumber. Good choices, right? And then there's some drinks that are great for sleep. Warm milk. Mom was right, you know. Some warm milk, almond milk, valerian tea, chamomile tea, tart cherry juice, passion fruit tea, and peppermint tea. All of those are good choices to help you relax. Now, the worst foods, you won't like this list. All right. It kind of looks like the American dream. Food and drinks that contain caffeine. Caffeine is a no-no. It's going to cause a lot of disruption, and we certainly shouldn't have it after 6 o'clock. Spicy foods, alcohol, again, nothing after 6 p.m. And that just doesn't fit into our social life, but that's a problem. Foods that are high in fat, foods that are high in protein, and foods that contain water. When you're going to sleep, you need digestion to slow down, not to speed up. Heavy meals before bedtime, just not a good way to get a good night's sleep. And we've all experienced that, eating too late at night and not sleeping well. So, what are some lifestyle interventions to increase sleep as we finish up here? Uh, First of all, again, you're not going to like some of these. Decrease the caffeine and alcohol and nicotine because those are all going to be disruptive. Physical activity is really important. Studies have shown that people fall asleep faster, spend more time in deep sleep, and waken less often when they have regular aerobic activity. So, working out and going to the gym is good stuff. Sleep hygiene, which is kind of what we've been talking about here, is having a regular sleep wake schedule, not looking at your computer or your phone at night is really important. We've all heard about blue light. And what we see is that the blue light will really eat up the melatonin, so we don't get a good rest there. Um, no naps during the day. Taking a hot shower before going to bed is a good, relaxing way to get your body ready for sleep. And establishing a regular routine for going to bed and waking up is huge. So, developing some of those good habits there. Um, Another intervention is use of melatonin. You can buy melatonin at HEB, CVS, Walgreens, anywhere. It's cheap, cheap. And we make it ourselves, but it can be taken supplementally. Now, it should not be taken every day. And I know people that put it in their medicine chest and take it every day, and that's a misuse of it. It's used for getting you through a sleepless stage or sleepless episode in your life. You can use it for a couple of weeks, and that's fine, but not every night. Uh, what happens with melatonin is when you and I went to bed last night, our melatonin was at its highest level in our body that we make. As you and I slept, it broke down the melatonin so that when you and I woke up this morning, our melatonin was at the lowest level. So complicating it by taking supplemental melatonin is rough on the body. Relaxation techniques help you to sleep. Cognitive behavior therapy. Some people, like I said, have that love-hate blame game with the bed, and so that needs to be addressed in another way. Just a little bit about us. We have a 4 bedroom, 4 bath sleep center. We're up in Round Rock on your campus up here. We're accredited. We're in operation 4 nights of sleep. We have an incredible medical director who's board certified in sleep. We accept insurance, and we have a virtual sleep clinic that our docs meet with patients 2 days a week. And here's how it looks. Kind of nice, right? We really tried to make it look like a bed and breakfast, and patients come in, they go, "Oh, I thought this was going to be a hospital room." So they feel more comfortable. Each bedroom has a complete bath that's wheelchair accessible, shower, and everything. Very nice. At the bedside, we've got our equipment, a little bit of a hospital taste there, right? With those plug-ins. And these are the head boxes that all the leads are plugged into, like so. We also have all different types of CPAP devices. The conventions are just all over the place, everything from just a nasal to nasal and oral. Very important. And our website is listed here at the end, and a real interesting YouTube that you might want to check out as well. And I thank you. I think we're pretty close here. And if you have any questions, there's my Texas State email. Please feel free to email me. And now you can wake up. Thank you. Is anybody still here? Thank you. My pleasure.
Thanks so much for being here, Dr. Marshall.
Absolutely.